Hi, this is Mary Shelton from the Division of TennCare. We'll get started in just a few moments. A reminder to have your phone on mute, and then also if you have video capabilities, you may want to make sure that those are not connected and or have it covered up. Thank you. Bye. Hi, this is Mary Shelton from the Division of TennCare. We'll get started in just a moment. Another friendly reminder to mute your phone. Thank you. Hello. This is Mary Shelton with the Division of TennCare. We'll get started in just a minute. Thank you.
Okay.
Good afternoon, everyone. This is Mary Shelton from the Division of TennCare, and we will go ahead and get started with our webinar, 2018 HealthLink Program Enhancements. So again, this is Mary Shelton. I'm the Director of Behavioral Health Operations here at the Division of TennCare. I will be on the webinar today and also joined here by Constance Payne. Hi, everyone. Constance, you want to introduce yourself just real quickly? I know everybody gets emails from you quite a bit.
Sure. So I'm a health policy associate here at TennCare. I work with the strategic planning and innovation team and work mainly on the HealthLink program. So I've probably met or talked with a lot of you all, and so I'll be doing the bulk of presenting today, just running through some of the program enhancements that you we'll see for 2018 and even a few updates for the current program year.
Great. So we're going to try something a little different this time. We are going to pause throughout the presentation, and we would really like to hear some questions from those that are participating. And we're going to take the questions over the phone rather than having you guys enter them into the chat function. So we're going to give that a try this time. I think that would help with our discussion, and I think it also helps with clarification and understanding of new information. So we'll prompt you guys when it's a good time to ask some questions. All right, let's move on to the next slide. So as has been eagerly waited by everybody, here are some HealthLink facts and figures from the first quarter and second quarter of this year. So we will email this out to you guys so that you will have it. And this is just raw numbers. We're not trying to play with it anyway as far as showing percentages, and we don't have enough yet to show a trend, but let's just look at this for a minute. So the first quarter, the total eligible members, and this does add the active members and the attributed not enrolled members. So that's 110,253. And then that has increased to quarter two at 126,317. So you can see how the numbers are moving up, our active numbers are moving up, as are our attributed not enrolled members. Those are increasing as well. So also, let's look at the total contacts and how we added these together. The total contacts number, you add the face-to-face and the indirect. Those are the duplicated numbers. The member and collateral, that would be the unduplicated. So we have a total of 301,058 contacts for quarter one, and then a total of 263,783 contacts for quarter two. So a decrease in contacts. Don't have any other information, just the numbers that are there. And we will be using this in combination with the information that the MCOs are gaining through their engagement evaluation that they are conducting, as well as just conversations with the HealthLinks. And this is, just casual conversations as far as how are you able to provide the HealthLink activities? Are you finding that after the first quarter, perhaps those HealthLink members that were enrolled, they're not necessarily needing more contacts, that you're able to maintain them in the program with one contact a month or with indirect contact more than face-to-face contacts? So those are just some questions and discussion items that we'll be having over the next several months as the program is growing and developing as we're understanding the service too, as we're still making that transition from level 2 case management to the care coordination model of Tennessee HealthLink. So as I said, we'll share this PowerPoint with everyone so you'll have these numbers. And we will also refresh these numbers in about another quarter. There are still some claims that are outstanding. We feel as though we have the majority of the claims processed, but there are still some outstanding, and I want to get as close as possible as we can to all the services that were rendered. And so once we refresh these numbers, we will share these again. Right, so that's what I have to share about facts and figures, and we can move on to the next section. And Constance is definitely going to be taking the lead on giving some updates to the programs. And, we've discussed with many of you either in face-to-face or at conferences or over email various components of the program that may be preventing benefit to the members, benefit to you guys, especially where you're working really hard for outreach to the members. But we can't fix things if we don't know if there's problems to the program. And so we really appreciate everybody's feedback, and we're as we can, we make those program enhancements. We're continuously evaluating the program, and if it's not operating as it's supposed to operate, then we can make that tweak. So with that, I'm going to turn it over to Constance.
Thanks, Mary. So glad all of you could join us today. We're going to go through a few slides here. We will definitely get a little bit in the weeds on some of these issues, so that's why, as Mary indicated, we'll pause to take questions in between, and then as always, Mary and myself make ourselves available at any time if you need to send us follow-up questions, if we need to schedule follow-up meetings, phone calls, etc. Happy to do so that you all feel really comfortable. I will just mention that all of the changes that we're making are provider friendly. So, we really are taking to heart the issues that you bring to us all, and then also the things that we uncover, as Mary mentioned, as we kind of analyze the program and how things are operating to date. So in most of these slides, I'll kind of explain what the impetus was for making these changes and why we thought that they were necessary and what that looks like in the program moving forward. So this first slide is a change that we've made to the outcome payment formula for 2018. So the first part of the slide, you'll see the current outcome payment formula, where efficiency improvement percentage is separated from the outcome savings percentage. And as some of you may recall, the outcome savings percentage is made up of your performance on efficiency stars and quality stars. So we had an extensive discussion and a review of multiple analyses from all three MCOs, and are planning to move forward with using the new outcome payment formula below for health links and low volume PCMHs starting January 1st, 2018, so second year of the performance period. And this new outcome payment formula, the main change that we made, you'll still see the same components, but there's been a restructuring of the formula. We were trying to make sure it was a bit more mathematically sound, and so what we did is we actually took efficiency and grouped that together. So you'll see efficiency improvement percentage is added into your efficiency stars, and then quality stars is its own individual component. Within that efficiency component or efficiency performance component, you'll see the efficiency improvement percentage is still capped at 20%. That's something that exists in the 2017 formula. You'll also see, and I'll expound on this a little bit more in the next slide, that we're actually going to take the efficiency stars down to 2 from 5. That is so that health links and PCMHs can really direct their focus to the 2 efficiency metrics that we think that you can impact the greatest, and that really translate into a significant cost savings if there's any leeway made with those metrics. And so in the new formula, each measure will be worth 15% if you're able to meet or exceed that threshold. As is with the current program, the MCOs will continue to set the efficiency thresholds for the program. The state will continue to set the quality thresholds statewide, but those are the main changes. Something else that this helps with, we were seeing a lot of folks, mainly because there was an issue with the 2015 baseline that we were using for efficiency. When we were showing in your preview reports how people were doing regarding efficiency improvement percentage, we were getting some negative numbers, some zeros, and that was causing the entire, quote, potential outcome payment to zero out. So this also helps protect against that. That way, if you are doing really well on one of the efficiency metrics, but maybe not as well, or maybe you were doing really well on it and you didn't get that extra improvement over the next year, you still can get to that outcome payment. It was as a focus of ours to make sure that, yes, we absolutely want to make sure that if folks are doing well on quality and doing well on efficiency, but maybe not necessarily getting that big difference in improvement in the efficiency year over year, because maybe they're already doing really well, that you aren't penalized for that, or not penalized because there's not any penalties in the program, but that you're rewarded appropriately for that improvement.
All right, so let's pause right there. Do we have any questions? Anybody that would like to offer a clarification? And you're also welcome to type it in the chat function if you want to, too. Okay.
The one other thing I'll mention, this is Constance again, is just to say that, as Mary mentioned, you know, just because we are giving you an example of these 2018 changes for next year, that doesn't mean that we don't continue to evaluate performance on the current year. So, you know, we're still looking at the outcome payment formula that we're using for 2017 to make sure that there's appropriate, you know, generation of outcome payments, because there's certainly an expectation that payments will be made. So I just want folks to, you know, realize that just because we're talking about these changes for 2018 doesn't mean that by any stretch of the imagination we've made a decision that there aren't any more changes to be made in the 2017 program year.
So, hey, this is Mary again. Just a reminder to put your phone on mute. I am hearing someone talk in the background. And Dr. Hudson, thanks so much for your comment. This is good news. We appreciate that. Thank you again. All right, let's move on to the next slide.
Okay, so this next slide, as I mentioned previously, is where we're outlining that we are making a change for 2018 regarding the efficiency measures. So both PCMH and HealthLink will move from 5 efficiency metrics to 2 efficiency metrics in 2018. This is going to help us simplify the model and allow, as I mentioned, providers to focus on more intentionally on fewer efficiency measures. The remaining efficiency measures will continue to be included as reporting-only metrics in your reports. So you'll continue to be able to track your improvement, and you know, certainly we will continue, as always, to reevaluate which efficiency measures you're being held accountable for directly as it relates to your outcome payment in the program. So, you know, we still want you to be able to make some strides in those other efficiency measures, but when it comes to the outcome payment formula, we'll be focusing on ED visits per 1,000 member months and then inpatient discharges per 1,000 member months. These are both measures that we feel really confident don't have as much volatility year over year, and feel like if you're really making improvements in these efficiency measures, then it would merit an outcome payment because it really directly translates into cost savings. Okay, so this is actually one change that I inserted here that is an update to the quality metrics for 2017. So we noted that performance continued to be very low for the HEDIS submetric counseling for nutrition for children and adolescents. And after conducting an internal review, we decided to remove the counseling for nutrition submetric from the HealthLink program, starting with the 2017 performance period, so this year. I just want to note that you will still see this submetric in your November performance reports, because we made the change and the MCOs weren't able to do the update because of the automatic process on those reports for the November reports, but it will be removed for all future reports. So you will no longer see this submetric starting with your February 2018 report. It had been brought to our attention that this counseling is typically already included it's included in the guidance for EPSDT requirements, and that separate coding for this metric isn't common practice. In fact, that the counseling typically occurs if an EPSDT visit has been administered. And so, you know, since health links are really already being measured on well care visits, which more closely align with the EPSDT requirements, we felt like, you know, that no longer holding health links accountable for that separate HEDIS metric was an appropriate call. So, you know, I do want to just again mention, it's not because we're not concerned about counseling for nutrition with children and adolescents and that we don't still feel that that's important. We just felt like it was captured through coding in a better way in one of the other metrics. So, and then below here is just that HEDIS definition. So if you're wondering which of the specific HEDIS measures or components that was, that is here on this slide. And I'll just also mention that this was based off of an issue that was brought to our attention by a provider. So again, I'll just say that if you notice or have questions or concerns or, you know, rationale or reasoning behind a particular change that you would like to see in the program, please bring that to us. It's certainly not to say that we can, you know, make all of the changes that are requested, but we really try to make a good faith effort to evaluate everything that's brought to us and see if it's something that's an option and if it won't be too disruptive and if we can move it forward with MCOs.
Absolutely, and I believe, Constance, you sent this out in an email to the Health Links a little over a week ago, so they have information about this in your email as well. So pause right here. Any questions or comments about this update to this quality metric? Okay. All right.
Okay, great. So the next couple of slides cover a topic that's actually new to you all because it will be new for 2018. And we call this quality metric reweighting or redistributing. Again, as I mentioned, all of the changes that we're making are provider friendly. And so this was a particular change that we made to try to address the issue of certain practices not being able to get to that 30 observations in the denominator on certain HEDIS measures. So as most of you know, HEDIS requires that quality measures must have at least 30 observations in the denominator in order to be measured. And so beginning in calendar year 2018, if an organization doesn't have 30 observations for a quality metrics denominator, the value of that measure may be redistributed. There are a couple of goals that we're trying to hit by introducing reweighting, and that is to reward high performance on measures for which organizations have a sufficient denominator, and then also give lower volume providers the same opportunity to earn a percentage of the outcome payment that is based on their high quality performance on the measures where they do meet the denominator. So a couple of guidelines for this particular topic. Organizations will still earn quality stars by meeting or exceeding the threshold for a metric and all of its submetrics if applicable. The potential value of each ineligible star, so stars where you don't meet the denominator, will be redistributed so that the total value of quality performance could still reach up to 50%, as you can see in the slide where we talk about the new equation. For example, if an organization meets the denominator for all 10 stars, each star is still worth 5%. But if that organization meets the denominator for 9 of 10 measures, and also, meets or exceeds the threshold, then each star is worth the 5.56%. So a couple of guidelines. Organizations must still meet or exceed the threshold for 4 stars to qualify for an outcome payment. So that particular component of the program has not changed from 2017 to 2018. The value of up to 4 stars may be redistributed for HealthLink organizations, but not any stars above that. So if there are 6 stars for which the organization does not meet the denominator, only the value of 4 will be redistributed. And then just also want to note that the value of composite measures will only be redistributed when the minimum denominator is not met for all of its submetrics. And I'll give you an example of what that looks like in just a second. So a little bit more about that submetric component that I just mentioned. Organizations will be measured on their performance and therefore eligible for a star for any metric for which they have a sufficient denominator in at least one submetric. So organizations must still pass the threshold for every eligible submetric in order to earn a star. A good example of this is now this particular quality metric, you will notice that in this example, we've removed the component of the weight assessment and nutritional counseling that was nutritional counseling because you're no longer be measured on that, but you're still measured on the BMI percentile component of this submetric. So for this example, on this BMI and weight assessment metric, there's 2 submetrics, adult BMI screening and BMI percentile for children and adolescents. So in the first example, a star would be earned under the guidelines based on an organization's performance on the adult BMI submetric alone. So you can see that they are panel eligible for the first measure. Their performance was greater than the benchmark, and then they did not happen to be panel eligible for the child and adolescent component, BMI percentile. And so in this scenario, essentially what it does is it masks or screens that weight assessment and just evaluates you based on your performance on the measure that you were panel eligible for. To compare and contrast this, in example number 2, you have the same situation where you're still panel eligible for the adult BMI screening measure, but your performance actually doesn't meet or exceed the benchmark, And so in this scenario, a star would not be earned under the guidelines based on performance on this submetric alone. So there's one kind of final slide on this, and it's I just want to note too, all of these changes will be changes that are incorporated in an updated provider operating manual that we will be circulating shortly. We're hoping to get that out within the month. So if you have any, and again, we'll also post these slides, but this slide kind of shows you a rubric for, you can look at the number of panel eligible stars and then the number of the stars you earned. And the blue boxes along the top designate the value of each star based on the number of panel eligible stars. I do, again, just want to mention that this is, the reweighting is something that will be going in for the 2018 program year. And I'll talk a little bit more in some slides to come about what that means for your reports and your report templates and what you would actually see in those reports and when, the schedule of that. But this just gives you an example. You'll see that there's, in the first, second, and third columns, there's lots of zeros because, remember, there's a reminder that you must be eligible for those 4 stars. That's still a requirement. And so regardless of what happens for stars 1 through 3, if you don't get to those 4 stars, there's not really a generation of a percentage for your quality stars. And then you'll just see how that distributes moving forward.
So we'll pause right here. What questions or comments or anything that somebody might want to offer? We'd love to have some discussion around this just to make sure that y'all are following this and that we're presenting it in a way that you can understand it. And then also we'll be working with the MCOs as well, and when they're going out on site, y'all can continue to have the discussions with the MCO representatives as well. Any questions?
Mary.
Hey, Mark.
Mary, this is David.
Yes, David.
Yes, hi, Mary, with PCS, and hi, Constance. I just wanted to go back to the few slides ago. I think it was page 5 or 6 where you were talking about the submetric that was removed, and I just wanted to make a comment that we as a provider group appreciate the collaborative work group that exists between the providers, the Division of TennCare, and the MCOs, because it was in that work group that we were able to identify and determine that submetric was probably not needed to be followed, and everybody listened, and we worked out a plan, and this was the result. So I just wanted to make a positive comment about that, an expression of appreciation, and also to lift up the value of that work group and its ongoing the ongoing effort to bring about very effective and positive changes in the program. So I just wanted to thank you for that.
Thank you so much, David. We appreciate that. Yeah, that's been a great work group, great meeting, a time to discuss through some of the complexities of the program, and then also to hear feedback on what the HealthLink providers are seeing as they're trying to gather information and reach out to the members, and as they're also looking through the reports. So thank you, David.
Hey, Mary, this is Michael Walsky and several other folks from Helen Ross McNabb.
Hi, good afternoon.
Hello. We have a question about those submetrics as well, just to clarify for ourselves. We know that the counseling for nutrition has been removed. Is the counseling for physical activity, is that included in that, or do we still have that submetric?
Hi, that's a great question. So actually, the physical activity component of that particular HEDIS metric is actually a submetric that we never included in the program originally. We saw pretty low denominators on that one and low performance, and so we initially never had that in the program. So you're correct in that that's also not a component, but that's not really a change because it was never really part of what was being measured in that composite.
Well, that is fantastic. Thank you. We appreciate it.
Welcome.
Other questions?
This is Carl with Navigate. I have a question leading behind that. So the activity, is it still a part of the well child Am I correct in that assumption, and to say that it's still a part of that, even though we don't necessarily have to measure that for HealthLink, but it's still a part of that Well Child Check?
Yes, that's correct, Carl. So as I mentioned, we found out through questions with other providers that counseling for nutrition oftentimes occurs within a well care visit because it's part of the EPSDT requirements. And so in an effort to not try to double count, and then also realizing that it wasn't typical for PCPs and PCMH PCPs to really code separately for that metric, we removed it from the HealthLink program. I will mention that part of that was because we found it, we know the HealthLink found it difficult to have non-PCMH PCPs update their coding practices when they don't, necessarily aren't trying to generate that outcome payment because they're not in a value-based payment program. We did leave the submetric in for the PCMH program at this time, and so the PCMHs are still being held accountable for that metric, but it's a bit different for them because they can update their coding practices and make that change and that improvement on that metric. And so we just removed it from a requirement for HealthLink, mainly because y'all aren't able to directly influence that coding practice.
Okay. Other questions?
I just want to make a clarifying point about the reweighting guidelines. So I know that was kind of a lot of detailed information all at once, and you probably need to take it back and take some time to absorb it before you have questions. But at a high level, the reason we did this is some HealthLink providers would get their reports and see that there's a measure that maybe they're actually doing really well on, but they have so few members that qualify for that measure that they weren't even eligible to get the credit for that star. And so what we have done is if you have less than 30 observations or 30 members that qualify for that star, then you're just not eligible for it at all and will give that credit to your other stars. So for those of you who have larger panels, this may not be a problem at all, and so the reweighting guidelines won't really affect you. But there were a handful of HealthLinks that did find this to be a concern. And so we're implementing this for both the PCMH and the HealthLink program next year. And I know it can seem complicated when you look at all these slides, but the best way to think about it is you will still be able to get all the credit for your stars. It's just that if you have a low denominator on one, we'll shift that value to the other stars.
Great. Thanks, Carly. That was a good synopsis. All right, let's move on to the next section, and Constance is going to talk about the outcome panel update.
Hi, everyone. So I know this particular topic is one that we've discussed off and on, not just in the same program year, but in the program years to come. And I had provided some clarification around how members are treated in your member panels for the 2017 performance year. Just to clarify that you do remain accountable for all of your members. If you look at the 2017 table here on the left, you'll notice that only if a member is inactive because they opt out are you not held accountable for your performance on the quality and efficiency measures for that particular individual. We've actually taken your concerns back internally and with the MCOs to see what update we could make to the program in 2018 to make this a little bit clearer. And you will see starting in 2018 performance year, if a member ends up in the discharge status, those members also will not be included in what we now call your outcome panel. I just want to note that the main criteria for someone being discharged is someone who doesn't meet the medical necessity criteria, and that might incorporate 3 different member groups. One is that you might have someone where maybe they're initially attributed to you and you bring them in for, their kind of initial check-in, and you determine at that point that they don't meet medical necessity criteria. So this might be someone where maybe there was a misdiagnosis of depression in the ER, et cetera. You follow up, determine that they don't meet medical necessity criteria and wouldn't benefit from the HealthLink program. So that member may be discharged out, and then you wouldn't continue to be held accountable for that member. One of the other options is that you have someone who really isn't making much progress in the program. This would be a member where you continue to do outreach, you continue to maybe even schedule appointments and services with them, but they continue to be a no-show. They're not invested in the improvement of their mental health condition. And so that would be someone where they would also not meet medical necessity criteria under that scenario, and you could discharge that member. The third bucket is one that we think is a smaller bucket, but we still believe it is an option, which is that someone really improves and stabilizes over time and can essentially graduate from the program. So they reach their treatment goals, they're back in a stable situation, they don't really need those care coordination services anymore. This would also be someone who doesn't meet medical necessity criteria, and we would also recommend that then they be discharged. I will note that just because someone is discharged doesn't mean that they couldn't re-enter the program after meeting Category 3 criteria, which is if you did an evaluation at a later date, a provider attestation, and determined that now they do meet medical necessity criteria, they're always welcome to come into the program and consent to receive the services. But this is just us trying to make sure that the people that are captured in your attributed panels and the ones you're being held accountable for and the ones that we are wanting you to improve the quality and efficiency of the care that they're provided are members that should be receiving HealthLink services. I do want to note, I have an asterisk here at the bottom, that it's still true that members must have been attributed to the HealthLink organization for a minimum of 9 months in order to be a part of the HealthLink organization's final outcome panel. So even if someone came into your organization as newly attributed to you, but they came in halfway through the year, that would be someone that you wouldn't be necessarily held accountable for as far as quality and efficiency, because they didn't meet that minimum 9-month attribution requirement. The one other slide I'll present on this, and then we can take questions about the outcome panel update, is again, so beginning in 2018, members with a discharge status will not be included in HealthLink's outcome panel after 3 months. This is to ensure that providers will no longer be held accountable for individuals who they have determined are not meeting medical necessity criteria for the program. As a component of this change, the MCOs will add in a review of discharges to their engagement evaluation process. That process is still under development by the MCOs, but we hope to have something to share with you all shortly. So they'll just fold that into the current engagement evaluation process, and essentially reviewers will pull records for a sample of members discharged by the HealthLink provider. And this is to ensure that providers are appropriately discharging members and that no one's using this as a catch-all for people that should be being pulled into services, but for whatever reason, maybe they're a complex patient, et cetera, and a burden on their workload. We don't want those people to be unnecessarily discharged from the program. So these are a couple of components. I will also mention that in this scenario, if someone doesn't meet medical necessity criteria, this needs to be evaluated with the member. So, when you're looking at medical necessity criteria, that's just a reminder to say that someone shouldn't be discharged just because you can't get in contact with them. There needs to be contact made with the member. For both things like discharge status and inactive opt-out, we require member involvement for that to be the scenario here. So just wanted to give everyone that friendly reminder.
Okay, so we'll pause right there. Any questions? And again, you may also enter that through the chat function as well. Okay. All right. So taking it back to Constance.
So the next slide, I mentioned earlier that I would kind of talk you through, give you an updated reporting time frame through the rest of this year and into 2018, early 2019, just so you get a feel for what your reporting schedule looks like now and when you'll see these changes in your reports. So I just want to point out that for all of the reports through the first triangle here of August 2018, for all of these reports, you'll continue to see the information reported in the current version of the reports you see today. So, you know, I just want to mention that you'll continue to see the outcome payment formula from 2017. You won't see any reweighting changes. I just want to mention that because it might be a bit jarring to feel like you're halfway through 2018 and you're still seeing reports with information from 2017, but that's just the way the reports generate. We have to build in that lag due to claims run out. And so the main thing to note is that in August of next year, in 2018, you'll receive 2 reports. You'll actually get the last performance report for performance year 1, and that will be the basis for each organization's 2017 outcome payment. But you'll also receive the first report for performance year 2, and that will be with an updated template. So you'll basically see those changes that we've talked about being made in program year 2, so in 2018, first show up in that second of those August 2018 reports. So just wanted to try to head off any alarm that people might feel when you get your reports. Certainly, if you have any questions about the reports when you get them from the MCOs about what you're seeing or why you're seeing it in that format, et cetera, they're happy to answer your questions and concerns. And as always, they will continue to be interfacing with you all. And I know that they have regular meetings and calls scheduled to answer any questions you have. But, you know, and certainly if there's questions that we can answer, we're happy to do so around the structuring of the reports. But when it comes to the content, the MCOs are really the source of truth for that information.
Thanks for pulling together this time frame. This will definitely be available in the PowerPoint when we release it, but how about let's carve this out and maybe make this a separate document. I think this would be helpful for the HealthLink organizations to print out and just have handy. And these may also be dates that you might want to enter into your own personal calendar at work. So thanks for pulling this together, Constance.
Yeah,
this
absolutely.
is helpful.
And I'll also just mention that typically the schedule we're on is to have the report released to you all by the end of the month and year that's listed on this report. So, for example, as an update, you will be getting your November 2017 reports here in the next couple of weeks. We're going to planning to release those by the end of November. So we have a bit of a QA process here on the state side and want to make sure that the reports go out are as clean and in the best format possible for you all. So you'll see those at the end of this month. Okay, great. All right, so the next couple of slides, you can take a sigh of relief and a little mental break because it's just a couple of updates about some of the other components of the program. So we've got a care coordination tool update for you all. The first item is just to mention a bit about the data accuracy. So the accuracy of member attribution lists has improved immensely over the past several months. We've been adding additional manpower in on the eHealth side of our team, along with Altruista, our vendor for the CCT, to work on, and with MCOs, to work on the accuracy of the lists that are imported into the tool. And so as of the end of October, the attribution error rates are calculated at less than 1% across all MCOs. So, you know, if you still have examples where you're saying, I'm providing a service to a member, but I can't see them in the care coordination tool, please make sure you report those issues to the help desk as an error. They should be few and far between, but if you feel like there's someone that's not making it on there that should be, you know, please let us know. One of the recent enhancements, as I've mentioned, is that the Social Security number is displaying in the My Members and Quality Measure tabs. That was in September. And you can also search for members by age, race, gender, and county as of September. Also, an update about the training materials. The training materials are updated on an ongoing basis to reflect changes within the tool. And demonstration videos are also being developed regularly. The newest videos include how to find your dual program members information and finding claims-based medication information. All those training materials can be found on the state's website at the Care Coordination Tool screen. And the CDPS webinar recording and presentation are also available on our website now.
I mentioned this at the Oak Ridge training, and I think, you know, something for us to be mindful of. I know not everyone logs into the care coordination tool, and it's handy we have a report showing how often each of the users are logging into the care coordination tool. And I'm just going to tell you, I'm blown away by how often some folks are logging into the care coordination tool. It is obvious that they're logging in daily, if not every other day. And I just want to encourage every agency to have at least one person to log into the care coordination tool daily, if not every other day, because these program enhancements are coming out regularly. The ADTs are being updated. But I just want to encourage you guys to use the care coordination tool. I know with any bit of technology, the more you use it, the more you are comfortable with it. And again, if you have any questions about the care coordination tool, definitely reach out to Altruista. And you can also reach out to Constance or me if you're needing some help or needing some specific advice. But just want to offer that encouragement.
Thanks, Mary. And so to talk about that, actually, we've got an ADT update for you all. We're really excited to say that now over 50% of total licensed beds in Tennessee are statewide are feeding directly into the ADT tab in the CCT. We're making some really significant progress on this number. We've still got a couple of folks to continue to do outreach with, but THA is certainly on track to reach their goal of having 100% of the THA member hospitals in the tool by the end of this year. So we really continue to have weekly, if not every couple of day updates on progress that's being made in this area. So just to say, take heart. If you are in an area of the state where not all your hospitals are feeding into the ADT, we have folks working diligently to improve the number of ADTs that are feeding in. If you have any questions or concerns about the information in the ADTs, please let us know. Happy to answer those questions. But we feel really good about the progress that's being made so far. I know it's been a long time coming, and so as Mary mentioned, if you can just continue to push your members towards using the CCT, I think the ADT information specifically is something that's really usable information if you're trying to find members, especially those hard-to-reach members, those ones that you can't find, because that information is updated in near real time.
Yeah, this is great news and definitely seen a significant increase over the past month or two. So we really appreciate THA's work on this.
Okay, great. And then just a quick Navigant update. The coaches continue to be available for on-site coaching at each of your sites. And if you can reach out to your coach or Rick at rwalker@ccwnc.org to schedule sessions, that would be great. The dates for the 2018 conferences are listed below. Just wanted to go ahead and give you all that information so you can go ahead and mark everything on your calendar. We'll have 3 conferences in 2018 like we had in 2017, and we're making some good progress on making sure we have good, agenda items and topics to cover with you all. So we've got February and March dates, June and October. I'll actually take this moment to issue a little plug. If there are topics that you would like to have covered during these conferences, if you can send that information to myself or Mary or Carly, really anybody here at the state, we're always taking ideas about information that you think it would be valuable for folks to hear. It's likely that if you find it valuable, some of your other colleagues might also find that information valuable. Navigant's really able to pull from a broad array of both national and local speakers and topics. So really we're happy to try to, these are your conferences and we want to make them as useful to you all as possible. We've had a lot of positive feedback about the conferences, but or changes to formats, critiques. I know you all had the ability to fill out those surveys at the end of the conferences, so we appreciate that. But if there's any feedback that you didn't add on there or you kind of talked about with your team after the fact, or maybe you had a debrief on the conferences and it's something you would like to share with us all, please don't hesitate to do that. Again, we really want to make these conferences as useful as possible. All right, the last slide before we open the floor up to take any additional questions is Jackie Wokeful was with us during our conferences last week, and provided a presentation on the medication therapy management pilot program. So I just wanted to share a little bit of that information in a quick little one slide just for your reference. Several months back, you received an email from me that contained some survey-related questions about your efforts so far for collaborative work with local pharmacists and pharmacies. And actually, we received a lot of positive responses, that a lot of you recognize the value of pharmacists and already have pharmacists or pharmacies kind of integrated into your care, collaborative agreements already in place. So this is another opportunity for you to enhance that relationship that you have with a pharmacist or a pharmacy locally. And so just a little more information briefly about that in case some of you weren't there at the conference or haven't gotten this information yet. The MTM pilot program will launch in January of 2018. It is a voluntary program. It reimburses pharmacists for providing MTM to eligible members in both the PCMH and HealthLink programs. So pharmacists will be working directly with members to identify, prevent, and resolve medication-related problems, and we'll be collaborating with you all and other healthcare professionals to resolve any identified problems. So really is a value add, especially with complicated patients. A little bit more about the members who are eligible. It's members who have multiple chronic illnesses and medications that comes through when you see a risk stratification of medium, high, or critical. And then also if there's a member who has pediatric asthma or pediatric diabetes, they're also eligible for MTM regardless of their risk stratification. Pharmacists that are providing MTM must have a Medicaid ID, a collaborative practice agreement, a network agreement and credentialing, as well as care coordination tool registration, training, and access. I think one of the most important components of this program is that the pharmacist will have access to the care coordination tool just like you all do. So when if you would be concerned about your EHRs interfacing, et cetera, you'll actually be able to do a lot of work together through the care coordination tool. So the pharmacist will see a lot of the information you all see, and you'll be able to see a lot of information that they see for the members that they are allowed to provide MTM for. If you don't have a collaborative agreement with a pharmacist, or maybe you work with a pharmacist but you're not sure if they're interested in participating, you can get a list of the pharmacists interested in participating by contacting the Tennessee Pharmacists Association. It's Micah Cost, who's the executive director, and his email address is here. Please utilize that as a resource if you're wondering what pharmacists in your area might be interested in participating and potentially linking up in a collaborative practice agreement with you all. More information about the program can be found on the MTM website. And then if you have any specific questions, you can email special email address, tencare.mtmpilot@tn.gov. Jackie checks that regularly, and she's happy to answer any questions that you have about that program specifically. But I know some of you might know, but I'm actually a pharmacist by training, and so I'm excited personally to see this roll out because I know the value that pharmacists can add to your healthcare team. And so if you don't already have that as an option, it's really another good resource that you all will have because you're in this value-based program. Just a good opportunity to introduce someone else into your healthcare team that really understands medications and the complexity of treating members with multiple chronic illnesses. You know, members can be on a lot of medications at one time, and so having someone that's there to evaluate to make sure you're catching everything therapeutically and treating side effects appropriately and making changes where necessary, I know for me would be a really welcome relief. So just a little plug about MTM in case you all didn't hear that during the conference.
Right, a lot of great updates on this webinar. We'll pause right here. What questions do we have? And you also may type your question or comment into the chat message box as well. Okay. Well, as always, Constance and I are available by email is probably the preferred way to communicate with us. Send us your questions or comments, and we'll be happy to get back with you. Also, your MCO representatives are available. Constance, thanks so much for these updates. This was a really good review.
Yeah, you're welcome, Mary. And as we mentioned, we'll be sharing both the recording and the slides with you all here shortly, hopefully we've got a state holiday tomorrow, but hopefully the beginning of next week, and then that way you can circulate these slides to additional staff if you feel that's appropriate, or anybody who wasn't able to join us live for the webinar today.
Absolutely. Thank you all for joining. Bye-bye.
Thank you.